My name is Buzz Constable, and I'm the chairman of the Old South Meeting House, and I'm very pleased to welcome you to tonight's event. As many of you know, the Old South Meeting House has, since 1729, been Boston's sanctuary of freedom, as Oliver Wendell Holmes characterized us. But it's really been the central location for civil discourse, not only in Boston, but perhaps as much as anywhere else nationally. So this kind of discussion is completely appropriate. So we've been around since 1729, but really the last 100 years, or in fact the last 94 years, have been particularly special because it was in 1916 when the Old South Meeting House and the Ford Hall Forum began a partnership that continues to this day. So I am really very pleased to welcome you all here and to introduce Jennifer Bernardi, the director of the Ford Hall Forum. Thank you.
Thank you.
Thank you.
Hello and welcome, everyone. It's my pleasure to welcome you to this evening's discussion presented jointly with Old South Meeting House entitled AIDS, Social Justice, and the Politics of Transformation. I'd just like to take a minute to say Ford Hall Forum appreciates our generous sponsors, especially our partners, Suffolk University. We also thank our members whose generosity make this free public event possible. If you're not already a member, please feel free to stop by our information desk in the back and join up. This event is being recorded and will be available as a webcast on the WGBH Forum Network. If you're sharing a comment or a question for our panelists, please approach the microphones here or here so that we can hear you and so that we can capture what you say on video. And of course, please take a moment right now to turn off your cell phones. Thank you. And now, as I turn the microphone over to her, please help me welcome our moderator for this discussion, Rebecca Haig, President and CEO of AIDS Action Committee of Massachusetts.
Thank you very much, and it is wonderful to be talking about HIV and AIDS in this historic place. Somehow, however, I don't think the Founding Fathers had these bright lights in their eyes when they were up here discussing this. So when we start the discussion, it is difficult for us to see folks, so it really is important you come up here to the microphone, and I'll try to keep this discussion lively and moving forward. So my role tonight is really just to help field your questions. Here's what the format will be. I'm going to introduce our panelists. I have pages and pages of their accomplishments, but with their prior agreement, I'm simply going to introduce them and let them begin to talk. And then I'm going to ask them a series of some questions just to get this started. And then around 7:15, we're going to open it up to all of you. So please be thinking about the questions you have and what you want to ask. We do want this to be public discourse. We want to be able to talk more and openly about how we're going to stop the HIV and AIDS epidemic in this country that has now raged on for 30 years. And we want to talk about all those issues that are impeding us from moving forward, but also talk about, I think, some of the progress we have made over those 30 years. So just starting here and moving across, I want to introduce to you Kevin Cranston, who's the director of the Bureau of Infectious Disease at the Massachusetts Department of Public Health. Kevin, thanks for joining us tonight. To his right is Julie Davids. She's the co-director of the Community HIV/AIDS Mobilization Project, more well known as CHAMP. And she's joined us tonight from her home down in Cranston, Rhode Island, but usually I see Julie all over the country doing her work. Great to have you in Boston tonight, Julie. Guillermo Chacon is to her right, and he's the president of the Latino Commission on AIDS. The commission has been around for many, many years, playing a strong leadership role on issues related to the Latino population, and it's a pleasure to have you join us from New York.
Thank you.
And finally, to my far right is Dazan Dixon Diallo, not very familiar to many of you tonight. I know she was hugging almost everyone in the room, so her reputation precedes her. She is the founder and president of Sister Love, which was established in 1989 and the first women's HIV/AIDS organization in Southeast United States. After this introduction, I'm actually going to sit on the chair and sort of have this be more of a conversation. So we're going to start with just a couple of minutes from each of our guests sort of giving their perspective on the epidemic right now, and then we're just going to have an exchange of thoughts and ideas about that. The framework we're using and the reason we use the concept of transformation is that we're at a very critical juncture in our country with HIV and AIDS. The President of the United States has announced a new national AIDS strategy calling for the end to this epidemic, has set some very concrete goals and objectives to do that. And as you all know, the President of the United States and Congress has passed health care reform in this country that for the first time will mean that people living with HIV and AIDS all over this country who are poor and can't afford medical care will have access to the care and treatment that they deserve. So we are at a critical juncture. There's many opportunities ahead, but there was also many barriers. And so we're just going to ask our guests to give a few introductory comments, and then we'll start with the conversation. So Kevin, may I ask you to start?
Be happy to.
Great.
First of all, thank you to the Ford Hall Forum for allowing me to be a member of this prestigious panel. It's a real honor to be here, and thank you, Rebecca, for your opportunity to be here as well. Looking at the national HIV/AIDS strategy, there are some very harsh or difficult to achieve goals of reducing HIV incidence by 25% in the next 5 years. We're proud in Massachusetts to have, in the previous 10 years, reduced our own incidence by about 50%. So we were seeing about 1,000 cases a year at the beginning of the decade, and we are barely making 500 cases a year in our most recent 2 years of incidence. So we're very proud of that. But the old intractables of the epidemic continue. We continue to see extraordinarily high disproportionate impact of the epidemic on African American and other black residents of the state, as well as Latino residents of the state. While we see reductions in almost every mode of exposure, injection drug use amongst heterosexuals, virtually across the board, we continue not to see reductions in the absolute numbers of gay and bisexual men or men who have sex with men, but I'm going to say gay and bisexual throughout the night. I hope you don't mind. Gay and bisexual men who continue to be infected at a rate of approximately 1 per day. I came into HIV work in part because I am a gay man, and the epidemic washed over my life as it did over the lives of my entire generation. But I also started working the epidemic in order to advance prior goals in my own life and in my work, to see the transformational work towards social justice, towards the equitable distribution of resources, particularly health resources, and to see the lesbian, gay, bisexual, transgender community achieve a level of equity and fairness in our society that would begin to address multiple health and social impacts on their lives. So the epidemic, in some ways, was an opportunity to elucidate some of those challenges and elucidate some of those goals. And yet the epidemic itself, even as in Massachusetts we have led the way in building greater levels of equity than I think in most parts of the country, if not parts of the world, we have yet to make a real impact on one of the effects of homophobia or heterosexism in our society, in seeing a gross disproportionate impact of HIV on gay and bisexual men. Gay and bisexual men, as compared to men who have never had sex with men or report to us never to have had sex with men, have about a 24-fold disproportionate likelihood to be living with HIV in the state. And that compares to unfavorably to other disproportionate impacts on populations that I hope we're going to delve into tonight.
Great, thank you. And Julie.
Hi, thanks also for the opportunity to be here tonight. I'm here also representing the HIV Prevention Justice Alliance, or the HIV PJA, which I'm lucky enough to collaborate on with Days On. It's a collaboration between CHAMP and Sister Love and AIDS Foundation of Chicago, and we have a couple key slogans that will explain what we're about. One is HIV is proof positive of injustice, and another is AIDS doesn't discriminate, but society does. And I think that what's important to recognize when looking at the epidemic in the United States is that on the one hand, you know, many of us are very easily, it rolls off our tongue to be able to say the epidemic tracks along lines of social inequality, like poverty, like homophobia, like racism. But on the other hand, we talk about, you know, we're going to end AIDS in 5 years, or even we're going to end AIDS in a generation. And sometimes I feel like we're kind of the, is it the snakes at the garden party? But as many of us in the HIV Prevention Justice Alliance, or those living with HIV, or at the front lines of the epidemic, you know, we're here to say, well, it may not be that it's going to end in a generation, but what can we do today that on the one hand will lessen the impact and suffering related to HIV as quickly as possible, and the other hand, set us up, get us ready for intergenerational struggle. The National HIV/AIDS Strategy that Rebecca mentioned has a very compelling vision. You know, and a vision is not something that's going to happen in the 5 years of the plan, but it's something that we have the vision of moving towards. And I will paraphrase, which is that HIV in the United States will become rare. Even the vision is not that it will be eliminated, but it will become rare. And those who are infected will have unfettered access to high quality care and treatment regardless of age, gender, sexual orientation, gender identity, etc. And while we agree with that vision, we think it's really going to take a lot of political courage to get us there. As the HIV Prevention Justice Alliance, we're focusing in on 3 social drivers, 3 of the kind of social surroundings that we believe are driving the epidemic to be at such a level of persistence and severity and levels of inequality in the United States. The mass imprisonment of more people than has ever been seen on this planet before, as we know, is disproportionately people of color. The second is housing and homelessness. There's a lot of very compelling data that looks at not only how lack of housing creates compelling reasons to have risky behavior, but also the provision of housing leads to better public health outcomes, including people with AIDS being healthier and people being able to access HIV prevention. And the third is the marginalization of lesbian, gay, bisexual, transgender, and queer people. So these 3 social drivers, while we believe we need to continue to have very specific HIV-specific interventions, such as condoms everywhere, we also need to not be going it alone and making common cause with those fighting for housing against the prison industrial complex, for the rights of LGBTQ people to move forward on actually impacting the epidemic on a mass scale over the coming generations. You know, Kevin spoke quickly about using the terms gay and bisexual men rather than MSM, or men who have sex with men. And that he went through that quickly, but throughout the Bush administration, you could not say, for example, safely in some grant proposals or public meetings, gay men. You had to say MSM. It was hard enough to even say men who have sex with men, right? And there was a lot of myths. There's been a lot of, salacious reports about men on the down low. I think we just need to really fess up. And as the National AIDS Strategy courageously says, we will never get ahead of the AIDS epidemic in this country if we do not focus our efforts on gay men. And that really came to me in a flash just a couple weeks ago. That's why we never had a national AIDS strategy before. I mean, of all the reasons we didn't have it, that's, I think, one of the main reasons, because you couldn't have anything that was not laughable that didn't say that. And now we have a report that says that, that's come from the White House, and which the different agencies of the federal government have to report to the president by December 9th what they're going to do to implement this plan. So I think we need to just kind of spread the word and marshal our resources. Particularly hardest hit are gay men of color, but even amongst white gay men, 25% are already HIV positive. Okay, so we just need to know that in many studies, men who have sex with women and men, so-called down low, no matter what race, have lower infection rates than men who just have sex with men, i.e. gay and bisexual men. So that means that to get ahead of the epidemic in this country, we need to look at things like parental acceptance. What are we doing? What is our government doing? What are we doing locally? What are we doing in our private institutions, in our houses of worship, to help parents accept their children, no matter what their sexual or gender orientation? Because this has been correlated with public health outcomes. So there's a lot to be done. It's also, I sit here kind of sadly today, though, because within the next 2 weeks, we're going to see the imposition of a waiting list for AIDS drugs right in Rhode Island, right across the borders of Massachusetts. And this is, even as we have an ambitious AIDS strategy, we have a perfect storm of economic crisis, more people being able to access HIV tests, and some people testing positive for the first time and trying to come into services, and rising costs of the AIDS drugs, that we're seeing waiting lists of people that need medication, that qualify for it clinically, can't get it in this country, and now can't get it a 45-minute drive away from where we sit tonight.
Julie, thank you. Guillermo.
Thank you. I'm happy to share this evening, and this is a very important forum. But also I thank you, each of you, to making the time, because you're present, at least, you know, for all of us, I'm sure it's a sign of hope that the community care, that the community are interested about getting involved and understanding better how can we address this crisis in this country, and it's global, a global crisis too. For me, I think the theme of transformation is perfect. You know, I mean, we are implementing healthcare reform that's going to change the way that we have been addressing HIV and AIDS. We have a new strategy that was unveiled on July 13, and I think that's, I will say, one of the best things to respond to a crisis is to show leadership, and I think the president is showing that, and I believe that the most important thing is for us, the community, to develop and adopt and embrace our own strategy, because we need to be accountable ourselves. You know, the tendency is to ask everything and to blame somebody else, you know, that he or she will deliver. And I think it's each of us that has to deliver when we talk about a crisis that took 29 years to develop a U.S. strategy to respond to this situation. And as my previous speakers already mentioned, touched every community. And I again, you know, in July 2012, the International AIDS Conference will take place in Washington, D.C. That means the world is coming to the United States to learn more about the epidemic, you know. And Julie was mentioned just that we're going through a crisis right now, because this new strategy, the timing was also with one of the worst economic crises in modern times in the United States. And I think it's hard when you want to do something new. It's like when you want to, you know, paint your apartment or do something in your house, but you don't have the money to do it. That is the situation that we're going through. And I think it's a transformational moment too, because we are in a global society. It's, the new social media has transformed, for good and bad, our lives. And I believe that the theme that we use at the Commission is that united we can. And I strongly believe that we need to keep in mind that a transformation force, if we really want to honor the theme of this evening, is to pay attention about our young people. And I believe that's a challenge for each of us, also to involve people that we care. And also, if HIV do not discriminate, please, we also need to do our own check-ins about our own phobias, our own homophobia, transphobia, agephobia. And Kaiser Family Foundation, that is one of the premier organizations that follow up and analyze healthcare, they were polling recently, and it's amazing the lack of basic knowledge about HIV and AIDS. And at the end of the day, we need to keep in mind that HIV is preventable, but if we do the education in very diverse ways, and also, you know, at young age. I think that's my 2 minutes.
Thank you very much. Dazon.
Wow. Well, thank you. This is such an honor. I am definitely a Georgia girl, born and raised in Peach County, Georgia, the original Peach. And so my first thing is to say not only thank you for being here, but thank you for keeping it warm for us, sister, when I got here today. I am really challenged, you know, and as my colleagues, I am sure, are as well, but they've articulated it so beautifully. I'm challenged to pull together all of the different pieces that have to come together to make sense in just addressing the question that you posed to us, Rebecca. And one of the things that, as I was sitting in my room preparing for this evening, as I teach human rights, And for those who do know me, we are really deeply engaged in my organization in making sure that we articulate the fight against HIV and AIDS within the human rights framework, that we make sure that we can locate every challenge, every barrier, everything that either discriminates, exacerbates stigma, diminishes opportunity for access to care or for information, that every story of everyone in this room and everyone living with HIV, you can locate that experience in the dimension of the human rights framework. And the challenge for us with HIV and AIDS is that that human rights dimension is enormous. So I was reading the Atlanta, okay, I'm not going to call it the Urinal Constipation like we normally do, the Atlanta Journal-Constitution on the way here today, and just a few stories, because when I do human rights education, I use newspapers to find human rights in the headlines. How do we see things that are being protected or violated? And there were so many stories just in today's paper that most people who are working in HIV and AIDS, if it doesn't say AIDS, they're not looking for how it's relevant. But for me, I can see it all. So first of all, I remember standing in the cold January 15, 2000, or January 12th or so, 2005, a few of us standing on the corner watching 12,000 parishioners of Missionary Baptist Church march against gay marriage in Atlanta, but there's a cover story on Bishop Eddie Long today. I am leaving the International AIDS Vaccine Conference, which is in Atlanta right now, and there are two thought pieces, one written by Alan Bernstein of the Vaccine Enterprise, and Eric Hunter, who is a vaccine researcher at the Center for AIDS Research in Emory, talking about the role and the importance of bringing the AIDS Vaccine Conference to the South. And it's critical because I don't know if people pay that much attention to what's going on down there. The Deep South, first of all, is much more than a geographical distinction. Y'all with me? The Deep South carries much more of the HIV epidemic as a region than the rest of the country. Black women in the Southeast together outnumber 4 times all women living with HIV in the rest of the country, bar none. But in that same region, you're also talking about, we are, of all of the states that have just recently implemented their ADAP waiting lists, I think we're about 90% of the states that have implemented. In my state alone, we implemented the ADAP waiting list July 1. By August 1, we were the #2 state with the longest list. And as of last week, we are already over 500 people on a waiting list looking for their meds. We have the highest rates of syphilis, gonorrhea, chlamydia, high school dropouts, numbers of men who are not finishing school and going to prison, infant and maternal mortality, illiteracy. I could go on, but you understand that those same dimensions that we like to place out in the rest of the world and talk about the human rights problems there are right where we're living in the southern US. So this whole issue about bringing that vaccine conference just to the South to relate and bring folks around the world to see what we're dealing with right here in the United States before 2012, because some of us can't even wait that long, has been important. And sitting right next to that article is a piece written by former President Festus Mogae from Botswana, who was one of the leading champions on ending HIV in Botswana, who talks about the president mustn't retreat from the original pledge to help Africa fight AIDS. That's just another one. Today, the ARIS program that has provided funding across this country to restore work for single parents is ended without any level of extension. In the last 4 months, I have hired 4 HIV-positive women who are now back out there going to have to look for work simply because Congress can't get its act together. So, I mean, we could sit and talk about all of these particular issues in the pockets where people are doing the work, but HIV itself offers us the best opportunity to drill a lot deeper into some of these social issues and to do it in much more organized and mobilized ways to connect with those non-traditional HIV partners that we have yet to tap. The last thing I wanted to say is on the National HIV/AIDS Strategy. Guillermo has already talked about the role that the healthcare reform, as well as what's going to happen to Ryan White, all play within that. I do applaud the strategy for, and for the White House taking the leadership on naming the most populous community in terms of the epidemic in gay and bisexual men. But we got a paragraph on women in the implementation plan. We don't have any specific targets or instances that talk about the fact that whether you're in the South or in any other part of the country, black women occupy the spaces in this epidemic like no one else. And it's not directed in the sense that, what are those issues? And the youth are not explicitly identified in the strategy. The incarcerated are not explicitly identified in the strategy. So the questions we have is not just what you gonna do now, Spanky, because I like saying that, is why aren't they there? One, how do we get them there? Two, and that it's not going to be what we see, and I think we also have to keep our eyes on this, we are not going to be able to just treat ourselves out of this epidemic. We are not going to be able to just come up with the drugs that are going to prevent or the drugs that are going to continue to treat HIV, but we're also going to have to come up with the other strategies and the other remedies that are going to end the things that drive the need for those drugs, the stigma, the discrimination, the poverty, the violence, the lack of access to mental health. So I guess if I would close and then probably open it up for a little bit of that controversy is that I do believe that the science and the research of all of this is why we're in it, right? The prevention research, the treatment research, the vaccine research, that the science and the research are the backbone to the fight, the end of the fight. I'm not confused about that. But community and civil society are the soul. And so with body and soul, that's the only way we're going to make this fight happen. And that's where the transformation has to happen. Y'all are here because you care. The next time you're here, you have to have somebody else with you who also cares, because that's the only way we're all going to get this done.
Great. Thank you very much. So in listening to all of you speak about this, it seems to me that part of the theme we're talking about is that there is not just one epidemic, that how the epidemic impacts different communities, whether those be communities, geographic communities, or communities identified in other ways, is somewhat critical. And that, to your point, Dazan, having a national strategy is critical and important, and having leadership. But I hear the implication that different solutions may also work in different communities, and we need to maybe mobilize different ways in just different communities. And I'm wondering if anybody has any sort of thoughts about that, or examples where we've particularly made inroads by working with communities and building community to make a difference. And I'll open it up and then.
Sure. I think we need to start with our success stories, because we have several of them in the epidemic. One of the first being, and I think it's a beautiful marriage of science and humanity, is the ways in which we have virtually eliminated perinatal infection in this country. And on the one hand, treating women during their pregnancy with a biochemical response does reduce transmission. But women have to know they're positive, women have to be in prenatal care, women have to be understanding the processes of how their own pregnancy and their HIV intersect for their own health and for the health of their fetus. And it really is ultimately about the women's healthcare movement building a capacity for women to support one another in and through anticipation of pregnancy and all the way through child rearing. And so bringing that together, I think, was essential. Just having the drugs available would not have done it. Another example is the injection drug use community, where many jurisdictions, including our own, are moving towards like single-digit proportions of new infections amongst injection drug users, where at the beginning of the epidemic was close to 40%. We only have 4 needle exchanges. I'm happy for them, but only 4 legal needle exchanges in Massachusetts that can't possibly meet the needs of all injection drug users. And through the work of AIDS Action Committee, we happily have now over-the-counter syringe access. But even before that was available, IDUs themselves were sharing the technologies, if you will, the skills, the techniques, the motivation to reduce risk, learning how not to share in wide circles, learning how to clean works, learning how to access sterile syringes even where they are not legal, and building among themselves a collective capacity to fight this epidemic. with almost no assistance. You know, those of us who are working hard to reach out, but many of the folks in the community we never directly touched. It was secondary and tertiary effects in that very community that achieved those goals. I think we have lessons to learn for all of our communities from these two examples.
Yeah, I just want to add to what Kevin was talking about with injection drug users, to deepen that by saying until a couple months ago, there was a ban on federal funding for syringe exchange. Right. So it wasn't just that people self-organized, it was the intentional neglect of a federal government that for over a decade has acknowledged that syringe exchange is an effective way of stopping the transmission of HIV without increasing drug use, but no thank you, we're not going to pay for it. And earlier in the epidemic, there was ridiculous myths out there like, oh, well, drug users, they want to share syringes, it's a bonding thing. That drug users themselves said, no thank you, we just need some syringes. And one of the things I think we need to look at now is I think we could have HIV in drug users be at kind of the success rate of perinatal transmission. We have the knowledge, we have the means to virtually eliminate injection-related HIV transmission in the United States, but we still do not have the political will. Sure. Drug users are not babies, and never will be. So I think there's communities and there's communities, and we're going to continue to struggle with that. I think that it's important to look at, but also realistically look at different communities of gay men and their loved ones in the country who did self-organize in the epidemic and invented safer sex and trained each other and supported each other, but with a grain of salt. I think there's a myth that kind of all gay men kind of, they went from Stonewall to the Castro to the AIDS movement, and some died, but the rest protected themselves, and they got all the resources, and everything was fine, they're okay. And I think one of the things that happened is that people lived through a death toll of genocidal proportions of young people and other gay men of all ages and all races, and scrambled together a pittance of resources that in this country has never been commensurate with the severity of the epidemic. So again, it shows what people can do when they come together, but it does not show justice. And we need to differentiate between that if we're going to figure out the way forward. And we also need to take a different grain of salt now and watch what we're saying about a current generation of young gay men. Because even within our own AIDS organization, there's a lot of stigmatizing talk and blame of saying, young gay men haven't seen enough people die. Excuse me? That's not going to be the solution, and young people think they're Superman and think that they are invulnerable. Well, actually, some research that combines body and soul has talked to some young people who say, I know very well what the life expectancy is of young people in my community. And that's why I realistically don't think there's much hope of me staying HIV negative. How are we working to truly empower young gay men and others in these communities who are starting to self-identify to be able to self-organize before they may even be able to safely come out? What are we really doing to have them break the mold of an other generation and not blame them and say, you don't know how bad it was? So I really encourage compassion and looking within our own HIV/AIDS movements and worlds and community efforts to say, are we spreading some stigma? Are we truly looking at community approaches that enable a new group of people to come forward, not just those who parrot what the increasingly older ones of us have said and what worked way back when?
I want to come back to something Kevin was talking about, specifically with some of the successes and how we look at them. And we're talking about moments and opportunities of transformation, right? So here's an example of where things could go wrong. In the near future, as we begin to implement healthcare reform, without a Ryan White, any undocumented pregnant woman is in trouble. So all of the successes we've made with perinatal transmission would just start backsliding in a minute. We've already faced that in Georgia, where we have positive women who are not documented, who cannot get any prenatal care, none of their meds or services, but within the Ryan White system, they can get all of their antiretrovirals. But we don't have a bridge between high-risk OB and what happens in the AIDS clinic. So of course we had to mobilize and work with the pediatric and the women's program in the Ryan White system to pay for the perinatal needs of undocumented women, because Ryan White does cover that. So you see that there are ways that we can build on those successes, or if we're not prepared, we're going to be back at the same table fighting those same fights all over again. And there's an example to that even within the national strategy that I think of when you're talking about, and I stand so much in solidarity with where we have come on the issue of gay men, bisexual men, and transgender women as well. But check this. So in the context of healthcare reform, women in the sexual and reproductive health and rights community got thrown up under the bus. And to put a positive spin on how do we deal with healthcare reform, because we're glad we got somewhere with it, right? That we start to look at the generalized text of healthcare and where women are going to reap the same benefits. But where there are specific issues around sexual and reproductive freedoms, that's non-existent for us. I can remember back in 1990, 89, when we were burying women by the month, and we were using that same approach to look at what AIDS is and trying to find the general perspectives where women could find themselves. And we couldn't. So we ended up with the campaign, you remember, women don't get AIDS, we just die from it. And it took a few more years for them to identify specifically some of those key issues that were immediately and uniquely relevant to women living with AIDS, to shift the definition. You saw the numbers go up, you saw women start dying less. It changed things. We're going to have to do the same thing with the National AIDS Strategy. Right now, we're trying to find those general texts that relate to women, but any of those things that are specific around mothering, parenthood, and sexual and reproductive health, none of those things are explicitly addressed, and we're going to be back at that same table again. So I want to caution us to, and this is always my message about the strategy, is that we have something to work with now. Recently, the U.S. Positive Women's Network, along with a national group of women who've been working on making sure that there was women's inclusion and girls' inclusion in the strategy, we sent a nice, wonderful, lovely, hard work document to the Office of National AIDS Policy prior to the strategy to see some of our stuff end up in there, but most of it not, especially around reproductive health. So what did that same group do? We put together our gender monitoring tool. We have a full analysis. You can get it at womenhiv.org. We have a full analysis, including a report card. I personally think we graded on a curve. For all you fabulous students who are in the room, y'all know what I'm talking about. It's a first draft of a thesis, so I think we graded them on a curve, and there's work for them to go back and do before it's a final product. But this is just a repetitive example of if we're not vigilant and if we're not doing due diligence to making sure that inclusion is there at the outset, then at the back end of it, we're still going to be trying to figure it out.
And Dejan, I just want to add, take the moderator's prerogative here and then hand it over to Guillermo. When you say women don't get HIV, they just die of AIDS, I wonder if the audience knows that for black women in our country, 25 to 34, AIDS is still the #1 cause of death. And whenever I hear that statistic, it's shocking to me, even as someone working in the field. And then to go ahead and say, and yet that women get a paragraph in a document. And I think it gets back to this issue of we have to deal with the epidemic in all of its different communities and make sure we have a strategy that works for that community.
I think the challenge, I think you mentioned in all of you in your remarks, that we're dealing with several epidemics at the same time. And we cannot afford to leave any community behind, because that means we're putting people at risk. A stigmatization for any community usually equals people will marginalize, will isolate, and then risk behaviors are a killer. And every time we talk about HIV, we remind people that unfortunately, and I was in a meeting in August in Washington, D.C., and was several researchers of the new medications, and they were saying that we are far, far, far away for a vaccine. And it's important, the meeting that is going on in Georgia, in Atlanta right now, but that means that we need to really have a balance between prevention and treatment, and in between keep investing on research, because every life, I think, if we lost one life, on this issue, and we know that it's preventable, And don't forget that the estimation is more than 56,000 new HIV infections in the United States every year. And that's, I think that's the challenge for all of us that work in prevention and education, but also is for the entire community as a whole. I also want to share with all of you that every time they invite me to speak, I told people I'm not going to judge how you behave and what you do. I'm very worried about how you do it. Because is this a way that we can prevent something to expose yourself, and especially when we talk about HIV or sexually transmitted infections, the deficit is that we lack a sexual education on the early age. Yeah. And we know that if we compare other societies in Europe, they're very aggressive to teach their kids at early age. And sexuality is very open, and the outcomes of people to value their bodies and how they protect themselves at the end of the day are good news. But also I want to share with the audience that we are very concerned because a lot of Latinos, Hispanics has been moving. Census 2010 just took place. And the projection of the data, some counties in the South has received 450% increase of Hispanics. Mm-hmm. And they realize, the local health departments, the county and the state, that they don't have the workforce to deal with this new community. And it's a difficult thing in the South, but also we have a huge crisis in Puerto Rico, the U.S. Virgin Island. Whoever visits U.S. Virgin Island, if you're in St. Thomas or St. John, beautiful place by the way, you will see a lot of Dominicans, that are there, a lot of South Americans that are there, and a lot of them undocumented. And then I'm calling all of you and all of us that also right after I will predict midterm elections, and please vote on November 2nd, and invite your friends to vote. We will have also a major debate on immigration reform. Yeah. And I was very happy a couple of weeks ago, Colin Powell, General Powell was on Meet the Press, and he was talking about that is something that we cannot ignore as a nation, and we cannot use it to really, because immigrant rights right now is civil rights, mm-hmm. and we cannot walk away and give it back to a reality. And my hope is in the next year, 2 years, that we will accomplish a humane, fair immigration reform, and hopefully healthcare reform, by the way, will be regulated by each state, will connect more people to care, and at the end of the day, hopefully we will have more healthy communities.
Just start being ready for, if you have questions, I'm going to ask a couple more questions up here, but then we definitely want to hear from you. So think about a question you might want to ask, and just about 5 more minutes, and we're going to open this up. It seems to me that the other thing we're really discussing here, when we talk about transformation and social justice, is that many of the people impacted by HIV and AIDS are impacted by so many of the other issues we've talked about. In our own community here, this very week, we've had another tragedy where 5 people were murdered in a neighborhood of Boston. Earlier tonight, I was talking to a colleague who said, when he tries to do the work he does around HIV and AIDS, his response from folks are, I'm just trying to figure out the safest route home in my neighborhood tonight. So it seems to me to get people's attention around HIV and AIDS, we need to be forming alliances with other groups that are also facing broader social justice issues. And I'm just wondering if any of you have thoughts about that or examples of what you're all doing to work together to address some of those specific kinds of issues that are also impacting and tearing communities apart.
Okay. One thing that a very successful way, we developed a partnership with Univision, one of the Spanish national networks, very powerful reach into the community, and that was basically, the alliance started between Kaiser Family Foundation and Univision to launch a national campaign to raise awareness, but also to reduce the stigma associated to Latino gay men, that by the way is the most impacted segment in the Hispanic Latino community nationwide. And that partnership allows us, it's a new campaign, it's called I Am, Yo Soy, and that campaign profile people living with HIV. And the beauty about this campaign is the public service announcements, the PSAs, are not aired at 3 o'clock in the morning. We ask them to air those PSAs during prime time, you know, during the middle of a major soccer match. You know, we Latinos, we have a big match, big fever on soccer. I'm a big fan of baseball. But they air those things during the prime time. And I told people, I say, we don't have the budget to buy 30-second, $250,000 ad during prime time. But that partnership, us supporting Kaiser and Univision, really allow us to do many things. And we are days away from National Latino AIDS Awareness Day that the Commission launched in 2003. And it's a national community mobilization campaign, and along with Univision and Telemundo and NBC, together we are able to really reach a lot of people because we didn't have the resources. And again, I told people in moment of crisis, you know, it's a test for leadership, but also for innovation and be very creative. And the partnerships and alliance, I think, has to be also the community level, especially with those groups that nobody want to embrace, nobody want to work, you know, homeless. At the Commission, we work with, long time ago, we launched a program, Hand by Hand, Mano a Mano, and that program is to give mini grants to Latino gay organization by country of origin. You know, Balgo is the Venezuelan gay organization, GALDE is the Dominican gay organization, et cetera, et cetera, et cetera. Mateando is the Uruguayan Argentina gay organization. And the beauty about these organizations is they begin to grow and become a nonprofits, and that provides so many services to the community. And it's another way not only to use the word empowerment, but make it real.
I just want to point out that Guillermo is such a gentleman that he mentioned baseball, and he didn't even mention the team he likely supports, knowing that he's here in Boston.
I like the Cuban national team of baseball.
Nice. I'm just going to let Dezat respond, and then we have a gentleman up here who'd like to ask a question.
So, and I thank you for that question, actually, Rebecca, because I've got two things about that. And one is an example of how we engage and build across lines. And the other one is a thought that, you know probably where I'm going to come from, and it's a little controversial on that. We need a little of that up in here tonight. But the example is, and I don't know if folks are familiar yet, but there's new campaigns from the anti-choice, the pro-life community that are specifically, and now they morph very easily. That's how organized they can be. So now their key target is Planned Parenthood, but originally the fight, they brought it to our communities by creating billboards, these anti-abortion billboards that said too many children aborted, or black children are an endangered species, and effectively targeting black women as if we are complicit and engaged in our own form of self-genocide. And the response was tremendous. We were brought in immediately because the context of reproductive rights and choice for women living with HIV is absolutely viewed, and women are targeted with that same expectation. Positive women shouldn't be having children, or if you're pregnant, shame on you, you shouldn't have that child because it's going to die anyway. So women who are living with HIV, especially black women, immediately understood the implication of that campaign and got directly involved in the anti-campaign or the counter-campaign. And let me tell you, these people have gone so far as they've recruited Alveda King, and this is where it comes together in the story. Alveda King, who represents Priests for Life from somewhere up here in New England, but Alveda King is Martin Luther King's niece. And she is engaged in this fight by using her homophobia and her pro-life agenda to identify black abortion and black homosexuality as black genocide. And by doing that, she has actually helped trigger a tremendously strong partnership in the civil rights community, in the LGBTQ community and the sexual and reproductive justice community. We are fighting it tooth and nail together, and everybody understands what it means if we're only trying to fight it individually. So that's just one example. I mean, even the Religious Coalition for Reproductive Choice recently had a press conference where there were all black ministers being able to talk about choice, being able to talk about women's civil rights, and able to talk about the rights of LGBTQ communities. That's where we have to take this fight, y'all. So the thought that I have in answer to your question, though, is one of the things we, as a community who are focused on HIV and AIDS, have to think about, wrap our heads around, and figure out how to move through is, and I'm not sure if I'm ready for the full elimination of it, but we're going to have to deal with what I call, or what many call, AIDS exceptionalism. We're going to have to de-exceptionalize HIV from the realm that it's been in for the last 30 years. And I want to back up and say, making HIV/AIDS the issue that we did for the last 29 years had to happen. It had to happen in that way so that we could generate the resources, that we could save lives, that we could mobilize communities, that we could challenge the public health system in different ways that it wasn't dealing with some of the critical issues of people who were most oppressed and whose rights were most violated. But now, that very thing that puts AIDS up on that special shelf is actually driving the stigma more when we're talking about getting communities of color, getting faith communities, and getting all of these other groups involved who are already working on all of these other challenges and haven't seen yet how they can deal with HIV and AIDS. When we normalize it, when we put it in the overall structure of it, that's when we're going to be able to see even better changes happen, because it becomes a part of the main course of social justice and not the dessert or the appetizer.
Now, I know we have a couple of other responses here, but let's get to the gentleman's question and then we'll come back. If you could identify yourself, and then if you have a specific panelist, please feel free to identify that, or we'll just have the whole panel respond.
All right. My name is Minister Charles Stokes. I am from Springfield, Massachusetts, and I'm an outreach specialist for Northern Educational Services, HIV and AIDS counseling and testing. And I was going to direct this question to you, Ms. Rebecca, and to Mr. John Cranston, but in particular to the whole audience. At our organization, we are the only African-American organization in Western Massachusetts, and we deal with people who have been marginalized and oppressed by this society. We go into the homeless shelters, we go into the soup kitchens, we go into all of the places that no one wants to go into, and we deal with those people. Let me back up, and I'm also a former crack addict and heroin addict. And I went to Northern Educational Services, and I learned through their paradigm, and that's how I got my life together. Recently, our contract has been taken away from us. After giving a 5-year contract, it was taken away from us because they say they can exercise a clause in their contract for no cause. Over the last 3 years, we have been asked to reach in 07 and 08, 288 people. We reached 470 unduplicated cases. In 08 and 09, it was 720. We reached 1,225 unduplicated people. And this year alone, we have reached 1,371 cases unduplicated. We have the 3rd highest zero rate in the state of Massachusetts. We talk about social justice. Well, there has been an injustice, and particularly when it comes to the African American community. How is it that we can do the work that no one else can do, and our contract can be taken away from us? And we talk about how we want to reach out and we want to help people, but you take away from the only African American entity in Western Massachusetts that does the work. And I listened to all of the wonderful panelists, but not one time did we talk about the plight of black men who are not being tested for HIV and AIDS. Black men who are afraid and vulnerable, who do not want to be tested, who die in misery. We reach those people, we talk to those people, and we get those people tested. And we talked about the injustice. Well, Dr. King said this, that injustice anywhere is a threat to justice everywhere. There's been an injustice done to the African American community in Springfield, Massachusetts. We're asking you, Mr. Kevin Cranston, we're asking you, Ms. Rebecca from the Massachusetts AIDS Action Committee, to tell us why this has happened to us. Tell us why. We sit here today and we wax eloquently about the disease of HIV and AIDS, but the only African American entity had their funding taken after 2 weeks ago being told we're doing a wonderful job. 2 weeks ago, we were told that nobody, Tapestry organization, don't go into the homeless shelters or the food shelters. They only deal with gay men and bisexuals. New North Citizen Council, a Latino community, they only go into the Latino community. We go into our community and we deal with our people from a cultural, holistic perspective. I'm the only minister that's not afraid to pass out condoms, not afraid to pass out bleach kits, not afraid to do presentations about this deadly disease that has killed hundreds of my friends. I'm 49 years old, Sunday, God willing, and I've watched and witnessed hundreds of my friends die from this disease, and now the Massachusetts Department of Public Health has taken away our funding to do the work that we do.
Let's like Kevin to.
Sure.
You want to respond?
Sure. It'll be tough to fully respond in this forum because it means talking about agency matters that, frankly, is the business of the agency, and I don't think it's appropriate to lay it all out here. And I've already chatted with the executive director, Ms. Baker, and committed to a full discussion of the specific issues around the contract. It is not the services that NES has provided for almost 20 years. We've been proud and happy to be a supporter of NES, and when we procured prevention resources just in the past year for July 1, it was also our pleasure to re-award resources to NES because of the superlative work you've done all these years. We are facing statewide, and I suspect nationwide, a serious challenge in the basic infrastructure of the community-based organizations that deliver HIV/AIDS services and related services. And without, I think, getting into too much specifics about NES, I think we're facing, in this economic crisis, multiple challenges to agency viability, multiple challenges to our ability to sustain our investment in an environment where the rules that we need to observe as a state funder may not be able to be observed at the fiscal level. It's still my commitment, my personal commitment and our organizational commitment to wrestle with the staff and the leadership of NES and the African American community in Springfield to figure out how to maintain services in Springfield specifically directed towards the African American community and to be delivered by members of the African community. And Reverend Stokes, I make that commitment to you as well.
Yeah.
After October 24th, the funding will be cut off. There will be people in our community who are practicing risky behavior and who are infected with the disease of HIV and AIDS. And right now, there will be no organized organization going into the community to do the work. So, and while we're wrestling with this, our people who are sick, suffering, and dying will continue to die. So while we're wrestling with this idea, let us remember the humanity of this.
Absolutely.
Let us remember that people are dying, and let us try to come to a quick resolution with this matter so we can continue to do the work and help our people who are dying.
Agreed.
Thank you very
Thank
much.
you.
And thanks, Kevin, for your response and your willingness to meet to solve this problem. We have a question over here. Would you please identify yourself and if there's a specific panelist?
This is really open to the entire panel. I'm Monique Toole, and I actually work with Rebecca at AIDS Action Committee. So a number of folks that I work with in the field here are sort of may think of me as kind of a broken record when it comes to hepatitis C. So here in Massachusetts alone, there's an estimated between 100 and 150,000 people who are living with hepatitis C. And yet there's less than 1% of what would be the AIDS budget devoted to hepatitis C treatment prevention. My question to you is, what do you believe is the responsibility of the HIV/AIDS community to people who are living with hepatitis C? Are there lessons that have been learned with HIV/AIDS and the service delivery system that we've developed from prevention all the way to treatment that can be applied to people who are not simply, that's funny, right? Not people who are also living with HIV and hepatitis C, but people who are mono-infected as well. So what's our responsibility? And more importantly, what's our commitment to those folks?
Sure.
Thank you.
I'd happy to kick off from a Massachusetts-specific thing, and then I will turn it over for a broader response. As you know, Monique, we fought hard. I don't believe response to hepatitis C is going to happen without the AIDS community. And I know that's controversial because there is a tendency nationally and even in our own state to subsume the dialogue around hep C under HIV, and that does take attention away from folks who are only dealing with hep C in terms of an infectious disease, but are sharing many of the same characteristics, life histories, social challenges of folks who are affected by HIV or HIV and hep C at the same time. We've made progress in Massachusetts in that we have rewritten the legislative language for the AIDS line, which is big. We get more money for HIV in Massachusetts on a per capita basis than any state in the country. We're graced by a very generous and supportive state legislature and governor. We have written into that language for the current fiscal year permission to utilize AIDS line resources for the associated conditions of viral hepatitis and sexually transmitted infection, for which we have 0 state dollars currently. And so that allows us at least to start to build out from our current structures, which are the community engagements, the public health surveillance activities, the medical treatment that we are so proud of here, being able to guarantee equitable access to HIV treatment. We want to build towards creating that same equitable access to viral hepatitis treatment. And just a little bit about your last question about the kinds of partnerships that are necessary. We got to work around incarceration justice. We got to work around building communities that support folks both in jail and post-release, because that's one of our populations so affected by hepatitis C, as well as working with young folks who are newly engaged in opioid addiction. And we see in our state a new bolus of individuals affected by viral hepatitis C as a result of early addiction, usually proceeding from pharmaceutical use. We have lessons to learn from AIDS and HIV, and there are new lessons that the HIV community has to learn about viral hepatitis, and I think we have to do that in coalition.
And Kevin, before Dejan steps in here, just to give our audience a perspective on hepatitis C and the breadth of the impact it might have, can you just share some numbers? There are X number of new infections and other diseases,
Certainly.
and here's what.
The question is, it's much bigger than we even know. We're counting 8,000 to 10,000 new cases a year. The numbers you quote are a reasonable estimate of hundreds of thousands of individuals, but we actually don't know because we have minimal resources for surveillance. There's minimal screening going on in most of our settings. It's a much bigger problem than this country is prepared to deal with. And because it affects incarcerated individuals and injection drug users in a predominant way, we have to refight those battles that we thought we fought at the beginning of the AIDS epidemic about raising up and bringing voice to communities that many politicians, community leaders, and maybe members of our own families are unwilling to address.
I see we have lots of questions. There's another comment here, and then we'll move back.
Really, it'll be short because it just backs up. When you talk about the AIDS community has to be involved, here's my broken record spiel on that, is that a part of what the AIDS community itself is going to have to do is share some resources.
Indeed.
A part of what the AIDS community is going to have to do is really get honest with ourselves about where and how we're spending these dollars and where we can do better when we work across partnering lines with some of these critical issues like Hep C. Because, the other part that we have in the AIDS community is we drive a leadership of people living with HIV to the front lines to make sure that the lived experience is a part of the advocacy, and that's what makes the changes happen.
Indeed.
You don't have a Hep C advocacy. There's no Hep C movement. There's no gonorrhea movement. There's no chlamydia movement. There are no support groups, for HPV. So it's a common thing for me to just get real, that within our own community, we're not only talking about HIV, but we're dealing with hepatitis C and access to care and services. And I come from a state that, with the exception of ADAP money, has $0 in the budget for HIV, period. That's right. So there's a huge challenge just in getting equitable resources across the states to start to deal with it, because HIV, Hep C, and STDs are also migratory. They move and go from different regions where people have better access. That's right.
So I'm going to keep going back and forth. Just please limit your questions as small, small much time as possible so we can reach all of you. Yes, please introduce yourself.
Hi, I'm Hadia Charles, and I am a master's in women's health student here at Suffolk University. And I have also spent the last 10 years working in the field of HIV/AIDS, specifically around African American women and men. And as a community organizer, I was always challenged with the fact of how to bring the message across to heterosexual men, whether they're black or white. And I'm wondering, how do you think we will be able to move forward in our fight with this pandemic when we start to say that, gay men or gay sex is really fueling the epidemic, when there's such a concentration of terms around the type who has this sex, then I feel like it leaves out a very important aspect of our community. And when, Rebecca, when you mentioned that there were, that black women were dying of HIV and AIDS, it begs the question, well, where are they getting it from? And so with that in mind, how do you, what advice would you have, and how, and I would also challenge us to think about ways that we would message our prevention efforts so that it captures entire communities and not just one or two communities.
Julie?
Well, with all due respect to Hadia, who's one of my bosses as a CHAMP board member, thank you for that question. And I wanted to take the opportunity to give a partial answer that I wanted to give to the last question that Rebecca raised. So it's only a part of the answer to this complex problem, which is to say, I think for many people in this country, one of the best ways to deliver HIV prevention is so they never have to think about HIV prevention. I mean that very provocatively. Yes. I think if we worked, for example, to drastically reduce the over-imprisonment that goes on in this country, we are going to see less people have HIV, including many less heterosexual men of color or heterosexually identified men of color. And I say that answer not just because of my political beliefs or my beliefs in justice and human rights, but because if we look at the dismantlement of entire community stability that happens when you imprison a preponderance of men from the community, how that dismantles family structure, how that changes the economics, the opportunities for work, the opportunities for housing, the intergenerational relationships, the dynamics between different genders. We see again it's not just about people becoming infected when they're locked up, and it's not just about kind of creating conditions where it becomes very complicated to talk about non-consensual sex between people of the same gender. You're also seeing a concerted attack on the integrity of whole communities, and that leads to bad public health outcomes in all kinds of ways, that the answer is not just trying to beat someone over the head to use a condom. So I think one part of the very complex answer to that question is we need to really invest as people who care about HIV/AIDS in doing things like ending mandatory minimum sentencing in this country. And I don't care if I go to that fight really for mandatory minimum sentencing. I don't necessarily need to wear my HIV/AIDS hat. Yeah, it may help after I prove myself and my willingness to give and put myself forward. Oh, by the way, I work on HIV/AIDS, want to talk about it. But truly, we can contribute to these fights, not necessarily opportunistically even, but just because that will bring the justice, will be one of the elements in decreasing HIV in some particularly overlooked, marginalized, or hard-hit communities.
And I would just comment, I think the point of tonight is probably we will obviously be raising lots of questions for which we may not have answers or may not be able to answer, but we'll commit to keeping in touch with any of you and all of you that want to hear more as we go along, because I really do want to make sure I get a lot of these questions on the table, and I'm sure many of the panelists would also like to respond to that one. But let's go on this side of the room next.
Jefferson Miller, and I am a consumer, and I work at AIDS Action Committee. And my question is about ageism, if we're going to talk about social justice, and how it's complicated in the HIV population with the accelerated aging process, and trying to keep that in mind as we move forward. Now, the great news is that we have the ability to age now, and about 40% of the population is over 50 at this point, and that's really great. But talking about the quality of life of that, in many cases, a 50-year-old HIV-positive person has a cognitive function of an 80-year-old man. So there are ways and there are strategies, but to keep that in mind, it would be a real travesty to bring us this far and think that we have it licked and then see our quality of life diminish drastically. So asking you to keep that in mind as we move forward.
Absolutely.
Thank you.
Thank you. Guillermo.
I thank you for raising that issue, and I think many of us signed a letter to the National Institute of Health asking them to put in their list of research the need to understand and put more, because everything is connected, especially at the federal level. It has, and it's a reality, the fact that you just mentioned that we need to challenge all different entities, federal, state, local, and county, to understand that the age of those people living with HIV has been changing. And we talk about prevention, new strategy, but we cannot forget those people living with HIV and AIDS, especially those population over 50, because, and then we will be making the biggest mistake, I will say, and it's not to recognize that that population that is already living with the virus, living with AIDS, also need a hand of support, resources that are different than when they were infected, 20 years ago, 25 years ago. And I think that's a challenge for all of us and the audience as well to look both sides, not only those living with HIV, but also how we sustain our commitment to do a better job in terms of prevention, even though we're going through a very, very difficult economic crisis.
Thank you. Yes, sir.
My name is Carlo Dukes, and I'm HIV positive. And first and foremost, I'd like to thank everybody for being here. I'd like to thank you for bringing up this subject and making it known how important it is in the African American community to address this issue. And I know my friend got up here and he spoke already, but the main reason I come here is not to talk. I'm living proof of the work that these people, I've been HIV positive for 20-something years. And I can remember coming to Boston numerous times with them to advocate for calves, for different stuff over the years. And I just want you people to understand, I don't think anybody else, I firmly believe nobody understands our plight in our community like our own people. That's right. And not only the technical, formal job that they do, but I'm talking about people coming along. This used to be my case manager. Yep. She told me, you can live with this disease. She took me to NA meetings and gave me the courage to get clean and fight and live with this. In my, in my community, I believe, for me, that the biggest fear is anonymity. People are afraid to come forward and do what I'm doing today, right? Yes. They are so ashamed because of the discrimination and the ugliness that comes with the fear because of the ignorance of the disease and the stigma that goes along with it. People are afraid to say, I'm HIV positive. Yes. So you can't get anyone else to come into my community and make me understand how I feel but another black person. And I'd say that without no discretion at all. I mean that from the bottom of my heart. I thank God for NES. I thank God for them giving me the courage to be here, to live 20-something years, okay? Wanting me to be able to live with, I could not imagine nobody else. And my question is to you, who are you gonna pick to understand our problems? That's a social injustice, right? To take them out of our community.
Yeah. Thank you.
I think that you exactly represent what I'm talking about. When I say that and I said this in a talk in front of, 1,100 basic scientists who only see things in, DNA strands. And that was that while it's so important for the people who are focused on solving the problem, the researchers, the decision makers, the movers, the shakers, the purse holders, right? That while it's so important to be engaged and to have those folks championing the solving of the problem, it is as equally, if not more important, to make sure that there is a direct relationship with the people who know the problem. And that's what is missing. There's a disconnect in all of our communities with that. So that's one. The second one sounds a little funny, but I'm dead serious about this, is that especially when we're talking about our heterosexual brothers in the Black community, we need more than magic. And what I mean by that is that if Black people represent roughly about half of all the new HIV cases in this country, you cannot tell me that there is not another basketball player, baseball player, football player, bass player, hip-hop artist, movie actor who is not living with HIV since 1991 when Magic disclosed. And until, in my community, that's how we roll. Y'all know, we show up when there's a concert with a big name, not because you said HIV education is important. Am I right? So without that level of role modeling, somebody I want to be like, remember I want to be like Mike? We need more I want to be like Magics to come out and represent and connect to those very brothers, because they want to get involved, but the minute they do, the folks in our own community slap them right back, call them names, disinterested in them, put them to the side, and we can't afford to do that without creating a way for them to be safe and to be leaders.
I just want to add, I want to thank you for speaking, and also I think the best person to engage, to educate a particular community is a member of that community. But also, I think it's very important to challenge all the communities to work and support each other. Because I can tell you one thing, the Latino Commission on AIDS launched in 1995 the Latino Religious Leadership Project based on a meeting that we have with our brothers and sisters for an African American organization. We have been able to diversify many of our retention strategies, me meeting with the Pacific Islander organization. I have been able to increase also the visibility, meeting with an Anglo white non-Hispanic organization that is very relevant too. What I'm saying to you is we need to understand that the best person to go and engage a particular community is somebody from that community, but also we need to understand that we are all together. And if we don't bring the best that we can offer in terms of sharing lessons and supporting each other, we're not going to get far. And at the end of the day, what we want is the best for our communities. But as all the people that you were saying, and I like the way that you put it, and then the decision makers, we need to make them accountable to our aspirations, our needs, and our desires, because at the end of the day, again, whatever we do or we don't do impact all of us.
And Julie has a question, one comment, and then we'll get you a question.
I would just quickly like to say, and I'm honored to be able to respond to each of the speakers from the left and the right, whether it's about aging or who brought you to being able to live with HIV for 20-odd years, is also what you deserve and what we all deserve is a cure.
Yes.
We deserve a cure for AIDS. And we have lost sight of that. And yes, we need a vaccine, but the AIDS Policy Project is bringing some information together and bringing it back to all of us who maybe have brought our eyes to other things to say those basic scientists are coming up with some really interesting stuff about the immune system that says that a cure might not only be possible, but might be kind of within our reach, maybe within our lifetimes. But are we going to make the scientists work on it? It gets like this much funding right now. So I am, in the coming years, drawing more of my attention to cure-related advocacy in honor of those of you who have brought me to to have such an understanding by what you have gone through, what you've taught me of long-term survivors of HIV, to fight more for a cure and keep our eyes for a cure.
I just want to mention to the speakers, we've got about 10 minutes left, and I really would love for all the people who have questions to be part of the conversation, so try to keep questions and answers short. Thank you.
Hi, I'm Neil Cronin. I'm a Medicaid advocate in Massachusetts. Really proud of it, because Massachusetts, we have the lowest uninsurance rate in the country by far. We have more people covered on health care. We have an HIV drug assistance program that is reaching immigrant populations that are otherwise excluded from other programs. We are doing the right thing. But let me tell you one thing. This election matters. Yeah. This election matters. In my job, I am not allowed to be partisan. Tonight I'm off work. I am partisan. I am partisan. This election matters. We cannot afford to send Representative Perry to Congress. That racist, anti-immigrant, homophobe does not belong in Congress. We cannot afford to have Charlie Baker and his managed care mania run our health system. We need to keep a Democratic Congress, we need to keep a Democratic governor, and we need to get every one of our friends to vote.
I don't think there needs to be a response to that one.
Not at all.
Over here, ma'am.
My name is Ann Harris. I'm here on behalf of NAS. I'm here for, they have a voice for them. I'm also a consumer. I'm HIV positive. I've been HIV for over 20 years. I also have a son who's 17. He's HIV positive, and he just became undetectable about a year and a half.
Congratulations.
Thank you. And I'm asking if the money could be restored for NIS.
Okay, thank you. Over here.
Good evening. I'm Cynthia Harris, community member, mother, sister to a brother who's I lost to HIV, and employee at the Multicultural AIDS Coalition. So I actually thank the panelists for, this esteemed panelists. But first of all, let me stop. I thank the Suffolk University and Rebecca for the opportunity to do this, because I'm going to quote Jesse Jackson. He actually said, leadership is not choosing sides, but it's bringing sides together. So I appreciate the leadership there. I thank the panelists for, I think, the thoughtful answers, the fact that we recognize that things are missing from people were missing from the table when we were doing the National Strategic Plan, and that communities are important and all segments of communities are important. So my question is, given all of this that we know, what would the infrastructure look like, or what should the infrastructure look like to ensure that things like racism, homophobia, poverty, violence, substance abuse are addressed as we try to transform a system, given the politics from state to state and in the nation?
Oh, that little question. Dazon?
Well, okay. And you're my friend.
Yeah, exactly.
As is Cynthia. I just have a couple of thoughts about that very quickly, and one is similar to what I was talking about, and this is really basic. It's not like you're going to solve a whole lot of these problems overnight. That's not what's going to happen. We know that. There are two important things, though, is that with the strategy, what we have now is we have targets, right? And there are things that we're supposed to look at nationally. People need to be able to take, and I know that some states are already starting to do this and mobilize around it, but folks also need to start taking that national strategy and zeroing in their states so that they can have a statewide strategy that holds their state level accountable. That's the first thing. And then to tell everybody that it exists and to get folks informed about what's in the strategy. Because in addition to the strategy, there is an implementation plan. And in addition to the implementation plan, all of the current administrative agencies within the government have to have a strategic plan of how they're going to involve that implementation. But the second thing is this, and that is, just like we've created a gender monitoring tool that I still think we can work on and find the different issue areas, You look within your own communities of what those specific issues are that aren't in the document, and then you drive the report card to them around what's missing and hold those conversations, have that analysis, and move to getting those things included into that doc. As the president has said, the national strategy is a living thing, which means it can continue to grow and mature, and it is our job to nurture that.
Kevin, you have a quick response?
Sure. Two responses. One is there will be pieces of the infrastructure that's going to look different. All right. As we operationalize some of the powerful biomedical tools that are becoming available, and I think we haven't talked about some of those biomedical tools, and far away from cure, but way closer towards effective prevention and treatment than we have been before. We need to recognize that we're engaging clinical environments, and we have to maintain open and appropriate access to those clinical environments so those tools can be not reinforcing the very disparities that we've been addressing all night. The other side of that, though, is the very communitarian response that has to be maintained, because I think we're risking a solely clinical response to this epidemic, which is going to, I think we've heard amply throughout the evening, particularly from the audience, about how that's not going to meet the needs of communities in terms of identification of risk, identification of access points, being able to speak openly and connect with other folks with HIV and related conditions to be able to move forward in a self-promoting way and in a community-promoting way. And part of that infrastructure is not going to be AIDS-specific. It's going to be fighting for some of the things we've mentioned tonight: sexuality education in schools, full-scale reproductive health services for all women and their partners in this country, which we're so far away from. That we have to build a new approach to how we treat the incarcerated and why we incarcerate in the first place. We need to be addressing dynamics between men and women, between the old and the young, and fundamentally addressing sexual violence in this country if we're ever going to get a handle on this epidemic. And we need to build communities and their economic base. And that's not an AIDS agenda, that's a social justice agenda that we need to rejoin, because we benefited from all that work when we started the HIV movement. And in many ways, we were so successful in getting ours, we thought we could run it on our own. And many of us are renewing our commitment to our roots.
Excellent.
That was good. That was very good.
Yeah. Unfortunately, I think we have run out of time. I'm getting the high sign from my partner in the back. We don't want to, this lovely spot was gracious enough to have us here, and I want to apply by their rules. Our panelists will be here for a few minutes, and you're welcome to stay. I just want to start by thanking, really, as Guillermo said earlier, all of you. Because change starts with all of us, and our ability to talk to folks and to see new faces in the audience, and to recognize that some of us who are living with the disease or are fighting the disease have other allies. And it's so important for us to know that the work that we do and that the people who are living with this disease can see all of you here and know that people really do care. So we won't stop this public discourse after tonight. We will continue to work with the forum and maybe take additional topics and maybe try to find some other community meetings and come out to the western part of the state to ensure that you don't always have to come into Boston to have the discussions there. And go into the other communities that are represented here and have some of these same kind of forums. I would just add that Dazan will be at our offices in Jackson Square tomorrow to talk to women in the community, have a luncheon there. If any of you are interested, please go to our website, AIDSaction.com, and check that out, and you're all welcome to come. I want to thank all of our panelists again. It was incredibly interesting and exciting discussion. So we'll all be here for a couple of minutes, and feel free to come up and speak to us, but we do have to respect the building, and we'll have to exit in the next few minutes.
Thank you all.
Thank you.
Thank you.